The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Well, greetings and welcome to our LymphCast show, episode 54. We want to remind you to visit our website early and often. It's there for you 24 hours a day, and that is LymphCastNetwork.com. Everything is there. Everything you need to know about this show and more is there. Every show is on YouTube and every show is in podcast land. Wherever you go for your podcast, just type this in and you will find all 54 episodes. Let's go ahead and meet our panel tonight. We have a special announcement coming in a moment. But first of all, from Arizona, Dr. Monika Gloviczki. Hello, Dr. Gloviczki. How are you?
Hello, everybody. It's good to be with my team and with our distinguished guest. And I'm really excited to have this discussion today around the wound care, I think, right?
Mm-hmm.
So thank you for having me, and well, let's start.
All right. Sounds good to me. The gentleman who started this show with an idea a few years ago, and now we're already on episode 54. He is also the founder and owner of VitaSupport MD. They make Vein Formula 1000 and Lymphatic Formula 1000. From New Jersey, physician, surgeon, Dr. John A. Chuback. Hello, Dr. Chuback. How are you?
Hi, Paul. Doing well. Thank you so much. Looking forward to a great discussion this evening.
Excellent. I think we are ready to go. But before we kick off and bring our guest in, Dr. Chuback, you wanted to mention something about the New Vein and Lymphatic Summit, which will be chaired by Dr. Peter Gloviczki. Why don't you take it from there, and then we'll meet our guest after that, and off we go.
Yes, thank you for mentioning that. We have a brand new conference called the Vein and Lymphatic Summit, which is going to be this July. And it's very, very exciting because it's a completely virtual summit, which has many advantages, one of which is that people can attend from all over the world without having to travel. And this way, they also have access to these lectures and files and materials ongoing thereafter that they can access, watch again and again, and refer to. And of course, it's a great opportunity for people in industry and vendors who want to bring their products to the forefront and be seen by several hundred specialists in the vein, lymphatic, wound, lymphedema world, and also, apropos to tonight's discussion, the podiatry world. Dr. Monika Gloviczki and I and her esteemed husband, Professor Peter Gloviczki, have been working on bringing together sort of a new paradigm, a nexus, bringing the podiatry specialists, the podiatric physicians and surgeons into the world that we're used to navigating as vein, lymphatic, and vascular specialists, and realize that many of these artificial silos that we've been living in are just that, artificial silos. And I think it's high time that we interact and connect more in these medical and educational conferences, as many of us do clinically on a day-to-day basis. So with that, I want to say that people can go to VLS24, to look at the faculty. Dr. Peter Gloviczki and Monika, of course, worked with him on that. They've together put together an extraordinary faculty, an extraordinary agenda and curriculum, truly world-class. Physicians and clinicians that they've known for the last 25 to 30 years here and around the world will be on that faculty. All the big names, real experts. And I'm going to actually hand it over for a moment to Monika. Monika, do you have any thoughts or things you'd like to add about the VLS 24?
So first of all, I have to say to everybody that the idea came as we are ready to welcome the 5th edition of the Handbook of Venous and Lymphatic Disorders, and we really pile up the updated science about the various topics in venous, lymphatic, and lymphedema. And we, in a way, wanted to share this with the large audience of specialists interested in those topics, and maybe some patient healthcare providers. And so I think it was a great coming together with this idea of the totally virtual world, because this is really a beautiful construction. You know, you get into this conference. Matt, I think you should be familiar with the concept, because the podiatry was the first to launch it, right?
Right. Sure.
Yeah. So this is the principle that you are online, but you are getting into the building. You are getting into the conference room. If you want to chit chat with somebody about the newest product, you go to the industry exhibit hall. So beautiful virtual reality, and we hope great science, great faculty. And I think that everybody should enjoy it. Really, it's a fantastic idea to me.
Yeah, and the one other thing that I will add, Monika's added so much. There's so much incredible technology involved. And we should mention the conference coordinator, Rich Dubin, who's been working in the podiatry space for many years. He's done numerous, more than 50 of these virtual conferences on this platform that he's created. And it's remarkable. I'll just say one more thing before we introduce tonight's guest, and that is everyone is welcome. Everyone is welcome. Surgeons, wound care specialists, vascular surgeons, general surgeons, phlebologists, vein specialists, podiatrists, lymphedema therapists, certified lymphedema therapists, physical therapists, occupational therapists, and patients suffering from these disorders. Let's never forget that. Just as they tune into this show week after week and learn a lot and hear us addressing science, research, and a lot of heavy topics, I'm getting lots and lots of feedback from the public that they understand what we're talking about. They're interested in what we're talking about. And this is really an opportunity for patients to get on the inside track and see what doctors do inside of a conference and how we discuss these problems and share information. So everyone is welcome, everyone. With that, I am going to introduce tonight's guest, Dr. Matthew Rogulski. Dr. Rogulski is a podiatric surgeon and very highly respected in the area of wound care healing, but specifically immunology, micro and macrovasculature, and all of the destructive and reparative processes that are involved in the contemporary and comprehensive management of wound care and wound healing. Dr. Rogulski had a recent poster presented at the SAWC meeting, SAWC, and he addressed chronic wound healing and the concept and problem with the natural formation of bioburden, also sometimes called biofilm, and the formation of biofilm, which I know he's going to get to tonight. And I know that Dr. Rogulski and Dr. Monika Gloviczki have a surprise for everybody, which is, I'm going to blow the surprise right now, that they have had a poster together in surgical conference and medical conference. And so they know each other through that experience, and our dear friend, Dr. Mark Melin. So with that, Dr. Matthew Rogulski, welcome aboard, and thank you for being with us tonight.
Thank you, Dr. Chuback. This is just wonderful. I feel so honored and so privileged to be in company of such learned and visionary people. This is my absolute pleasure, and I thank you for having me here.
It is our pleasure. Dr. Gloviczki, would you like to begin with the first question?
Yes, I would like to have very simple first question. Why were you interested in wound care from the start? Could you?
Well, yeah, sure. I mean, my father was a diabetic. I come from a long line of diabetics, and before I went to medical school, my father was diagnosed with diabetes, and it was a struggle for him. It was very difficult for him in his 60s to how to check his blood 4 times a day, all of the information that he had to learn about nutrition and eating and exercise. It was just a lot for him, and I find that a lot in the diabetic population. They get very annoyed with it, have to take care of themselves, and as soon as they drop their guard, now it goes on. And they get problems from that. But that's what happened too with my father. Is he got tired of doing all of this, watching what he was eating, all these medications, seeing all these different doctors, because diabetes affects every system in the body. And when I went off to medical school and then did my residency, and then I got out into practice, he did develop a diabetic foot ulcer of his big toe on the left side. And I was just about 3 years out in practice when that happened. And it was a very difficult process for him. And where he lived up in upstate New York, there was some gentlemen that I did know, and I asked him to go and see them. And I tried to make appointments and get appointments for him. It was very difficult because he's 5 hours away from me. Subsequently, it really turned bad on him. It really went south, so to speak, developed gangrene, blood flow issues. He didn't get proper care in a timely fashion. I had to drive up there 5 hours, and I picked him up and I brought him back down here to New Jersey, where I practice here in Toms River, and stayed with me for 5 months. But unfortunately, I had to do a lot of surgery and partial amputations of his foot and heels, and did muscle flapping and grafting and all kinds of stuff to get him to heal. So, and 2 years later, he suffered a heart attack and he passed away. So, but he did have his legs on. But it was that kind of cemented it, because I was doing a lot of trauma surgery and things at that time. But that cemented me to understand the problem of not only the treatment that a lot of physicians don't understand, and that's why I developed Prepare to Repair, that they get too lost looking at the hole in the patient. They don't look at the whole patient. And Monika, there's multiple things that conspire to create a wound. There's multiple things that have to conspire to heal the wound. And I think people lose sight of that. There's multiple things that have to be addressed. There's not one thing going to fix this problem. And the wound healing space is so complex. It's very difficult to understand. As you're aware, in medical school, they don't teach anything about wound healing. They don't really teach. Even in my residency, we didn't get down into the real mechanistic approach to what is going on and how do we fix that. It was just macroscopic, looking at doing amputations and flaps and doing all these things, but not understanding the real genesis of the problem and how to address it on the molecular state. So my father's suffering was my impetus for me to get into this field and try to address those problems and teach and help people. But it just like Dr. Chuback, and we never stop learning as physicians. We're always reading, we're always looking at new data, we're always looking at new things, and can we do things more efficiently and do things differently? Is there a better way to deliver this care? But at the same time, it's education, both for the clinician and for the patient. So that was really my impetus for that, was my father's suffering.
Well, I think that it's a sad reason, but it turned out, for you, in the true passion of your life, and truly the beautiful service for your patients.
Mm-hmm. It is, and it's amazing out there. When you talk to patients, that they just don't understand these devastating complications that, particularly in diabetes, is going to cause. And I think because it affects every system in the body, they need multiple medications, they have to see multiple physicians, and they get tired and they get annoyed on it. But unfortunately, too, when you say that you get diagnosed with diabetes, my father was the same way. He said, okay, well, I could take a pill, or I could take a shot. But God forbid you hear cancer, you say, oh my God, I got to do this, I got to do that, I got to see this, I got to get. That's the problem with diabetes, is that it takes time for these devastating complications to accrue because of the chronic inflammatory process. And in fact, diabetes kills more people than all cancers combined. So it's, I wish that way we can get that across when they're in the pre-diabetic state, what is going to happen, what is happening inside their body, so that they can start to address that, both lifestyle and possibly through medication. But if we can get people, I think, just to eat better and exercise more, we could get rid of half the chronic disease that's going on.
That's probably true. John?
Yeah, I think it raises some really important ideas. The first of which is I think that our education about diabetes has to improve. And that's such a huge part of what we do here at the LymphCast podcast. The LymphCast podcast has in its name lymph. So people think that we're only talking about lymph, but far from it. We're talking about medicine in general. You know, we touch on every organ system and every subject, and the lymphatic system seems to be so much more central to that than we ever knew. That's why our show is called the LymphCast podcast, because it got no attention in our medical school training, et cetera. And so now we're kind of bringing to the fore that it's at the center of everything, perhaps. It really plays a central role and an important role. But that being said, just as the lymphatic system has been misunderstood and undertaught, I should say, and undertreated. The same is true of diabetes, although so many Americans are familiar with diabetes, they've heard of diabetes, they know someone with diabetes, or they have diabetes. My experience as a cardiovascular surgeon, and Dr. Gorski's point is very well taken. Cardiovascular disease kills more Americans than all cancers combined, and one of the huge risk factors for cardiovascular disease is diabetes, along with smoking, high blood pressure, high cholesterol, obesity, family history. So diabetes is central to that killer cardiovascular disease state. And the point that I'm making in all this is to get to this finally, that despite people knowing about diabetes, what they generally, the layperson, the public, generally thinks is, well, that means that I have high blood sugar. I have sugar, a touch of diabetes, and I have sugar in my blood. And so what I do, to Matt's father's point, is simple. I either take this medication and then I use the monitor and I say, hey, look, the blood sugar went down. Or I take this injection of insulin and I use my monitor and I say, hey, look, the blood sugar went down. We see it generally, I think, the lay public, the same way you would use a thermostat in your home. You say, well, it's hot in here. Let me turn the air conditioning a little cooler. And now that fixes the problem. Now it's cooler. I don't think we as physicians have done an adequate job, and as a healthcare system in America, letting patients know and the public know what the dangers of chronic high blood sugar are and how it affects so many of the organ systems, as you mentioned, Matt. And so we're going to talk a lot about that today and bring to light that high blood sugar, especially on a chronic basis, causes what we call end organ damage, meaning the small blood vessels in all of the organs of the body, whether it be the eye or the brain or the heart or the kidneys, etc., or the lower extremity, especially the microvasculature of the lower extremity, what we call small vessel disease. All of these areas of the body are affected and ultimately killed off, literally killed off by this high blood sugar. So Dr. Gorski has mentioned something I failed to mention in the introduction, so forgive me, what he calls the prepare to repair paradigm, which introduces his approach to wound healing and perhaps wound prevention as well. And I know he's going to have some slides to share with us. Now, if you're watching on YouTube, you'll be able to see these slides. And I'm going to give you a little bit of forewarning. If you're not a medical professional, I have had a preview of his slides. And some of the images are quite graphic if you're not a medical professional and accustomed to seeing that. So if you think that's going to be a problem, please be forewarned and maybe don't look at those images. Let's just listen to the discussion. But if you really want to see the dramatic and devastating effects that diabetes can have on the human body, then please look at them, because I think it's highly effective, although it can be disturbing and frightening. With that, Matt, I'm going to let you proceed perhaps with your presentation?
Sure. I'm going to share my screen here, and I'm going to bring it up so that everybody can see this. So this was let me go back and talk about, these are some of these pictures so the kind of the genesis of the prepare to repair paradigm. And this is a picture I show John a lot when I'm giving lectures, because this was an actual patient that came to our ER and thought she had a toe infection. Now, this was a lady that lived by herself, a little bit mentally slower, I would say. And she was virtually blind, had no blood flow below the knee, totally what we call septic from this infection. And she had a sneaker on, and the nurses took this off, and this was what was under her socks. Now, when I was walking down to the ER, and my one hospital here in Toms River is a very large hospital. It has 90 exam rooms in the ER. That's how big it is. It's the busiest ER in the East Coast here, Community Medical Center is. And so I could smell it. I mean, I was just getting off the elevators coming down, and I thought perhaps one of the toilets had backed up or something of that nature. And as I got closer, the smell became much more pungent. And the nurse actually said, you're not going to believe this when you see this. And I walked in there, and my residents were already down there, and this is what we saw. Unfortunately, this poor soul was dealing with this problem for months. And literally, I could just pull those are metatarsals for the patients out there that are sticking out, and I could literally just pull them out. So there was really not a whole lot to do here. The first thing to do is we just did a below the knee amputation to get rid of this stuff. But she was totally septic, and unfortunately, she passed away about 3 weeks later because of all the complications that diabetes affords them. But I think it's a pretty powerful picture because of the severe neuropathy that she did have. She had no pain at all. And neuropathy, as you mentioned, John, the end organ damage is, we can't forget about the nerve dysfunction that occurs in diabetes, both a metabolic and a vascular problem that leads to the engendering of the diabetic foot ulcer, because diabetics can't feel. So when my diabetics talk about having pain, I say that's a good thing, so that you can understand that there is a problem there. You can appreciate the gravity of the situation, because when you have no sensation, these things can start to develop just because you can't have that protective sensation of feeling pain, your body letting you know that something bad is going on there. So this poor soul unfortunately had to deal with this, and unfortunately lost her life at a young age of 61. But then also another good picture of gangrene that is going on in a diabetic patient. And unfortunately, I'm going to show you a couple of pictures of people that had this problem for months without being treated. And maybe, as we talked about previously, the clinicians not understanding the whole gambit of what is going on. Instead of looking at this hole in the patient, they're not looking at the whole patient. And John, you as a cardiothoracic surgeon appreciate blood flow issues, how diabetes affects blood vessel, and diabetes makes plaque. It's a chronic inflammatory process that occurs, oxidative stress that is occurring because of the hyperglycemia. Yeah. And unfortunately, this gentleman was dealing with this for 4 months. And you say to yourself, holy cow, for 4 months with this gangrenous foot like this. But multiple rounds of antibiotics, which is another whole discussion that we could have about antibiotics do not heal wounds. But yet it's being forced upon people. And that's why we have such high risk of antimicrobial resistance. As in fact, in 2019, 5 million people have died from antimicrobial resistant infections. We thought that was going to be 2050, but it is now occurring here in 2019 that has happened. So there's not a whole lot when it gets to this stage of other than amputating these parts, what we can do, and we should have had this gentleman 4 months ago. And then when I look at somebody like this, one of my good friends is vascular surgeon out here, did this beautiful long leg bypass on this gentleman. Beautiful. Problem was he's had this wound for 8 months, and the physician that was treating this had this gentleman soaking this in Epsom salt and putting Silvadene on it. And then his wife was putting 4x4s over and using an ace bandage and wrapping it so tight on the top of his foot, the dorsal aspect of his foot. He had rubbed the skin off, and saw the tendons were exposed. But at the same time, his whole heel bone is sticking out for 8 months. And I said to him, Norman, didn't you ask the doctor after a week or two of treating this, was there something else we could do? Should I go to see somebody else? And he said, no, because he's the doctor. He should know what to do for these types of problems. So I think the skill level out there dealing with these problems That's why all of us, we'd like to educate and train other physicians as well, because it is such a complex problem. You have to devote your practice to it. You just can't see these people willy-nilly. I mean, there was not much more to do because this was on a Friday, and he didn't want to go in the hospital because, really I'd have to do almost like a Symes amputation here. But at the same time, he didn't want to go in the hospital. He had something to do with the family over the weekend, and then he got septic too and went into the hospital on Monday. And my good friend, the vascular surgeon, ended up doing an AKA after spending the time and doing his beautiful long leg bypass that he did for him. So I think that's why the genesis of that. And then when you look at somebody like this too, John, this is a lady with big lymphedema on Coumadin, hit her leg and developed this large hematoma. 6 weeks. She had this hematoma, 4 different rounds of antibiotics. Now you say to yourself, 4 different, and I'm not saying anything, I'm not knocking other physicians, but, she goes back to the primary on a weekly basis. All he does is swab the area and gives her a different antibiotic. I mean, this.
Yeah.
Vein Formula 1000 and Lymphatic Formula 1000 from Vita Support MD are backed by science and sold in doctor's offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
I'm going to intervene right here, and I'm going to say that the reason that we have this program is it's an educational program. It's to educate the public. It's also to educate our colleagues and to educate one another and educate myself. I do plenty of learning on this show, but here's where I have to really be outspoken. And again, we're not here to criticize or sling mud at our colleagues in medicine and healthcare, but we have to be clear. If you are not a wound specialist, if you're not a podiatrist, a vascular surgeon, a general surgeon, or a wound specialist, and you're seeing terrible wounds like these, do not even attempt to take care of them yourself. It is time to call in specialists. That's why we have specialists, and we're blessed to be in a country like the United States of America where we have advanced training and so forth. I could see how a primary care doctor could be overwhelmed with these patients and kind of retreat mentally and emotionally and intellectually and say, well, I don't know what to do, so here's some antibiotics, and, go away, so to speak. But when we see these kinds of wounds, be sure that there are specialists, that this is the kind of work we do and we know how to handle it. And the sooner the better. And please, 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 don't think you have to be a hero. Don't think that you have to know how to handle everything. When you see horrific looking wounds like this, especially in diabetics, but it's for everybody, but especially in diabetics, because in a diabetic, these are emergency situations. These are the kinds of wounds people can die from within 24 hours. Okay. So send them to the emergency room and let somebody else get involved, because it's inexcusable that these people are languishing like this in this country at this time. I have to be outspoken about that.
Right. I totally agree. And that you need to form a team. It's a team effort. There's not one physician can fix all of this. It has to be a total team of multiple specialties really should be involved, developing a limb salvage team. And hopefully if you run across this, then you can get on the phone and call your friends on your limb salvage team and bring them in and get them involved for this, because it is a total team effort. There's
absolutely
not one person.
This is what we were talking about in the introduction of the show with the Vein and Lymphatic Summit 24, VLS 24, that we're bringing specialists together to look at the lower extremity as an organ system, as a complex organ: dermatology, infectious disease, podiatry, vascular surgery, general surgery, primary care, endocrinology, physical therapy. Monika, how many times have we been over this on the show, how these problems are so complex? These are not for any one physician to treat, correct?
Yeah, that's right. That's why in a way, the the team of the multi-specialists is so much more efficient, because if you have something like this, you get together with another people who have more maybe different approach to the wounds or to the diseases. So that's certainly something that reinforces the importance of the teamwork, simply.
Yeah. And and to our colleagues, let me be clear. It is not a failure to call for help, to call others in. The best physicians and surgeons I've ever known in my life have always been team-oriented. Bring in as many experts as you can in complicated problems. Somebody's life is at stake.
Yeah, right. Considering a diabetic foot ulcer has a 50% mortality rate, it's wonderful to have multiple doctors talking about it. And especially at teaching institutions, you would think that those lines of communication are even open more rapidly, but sometimes it's not. And, a lot of us have to institute that communication and get physicians together and talk about this, because I never stop learning, John. We always talk about that. We're constantly reading and looking at new things and new efficient ways. And is there things we can do better? Because medicine's constantly evolving, but these patients are getting sicker, and it requires a total team effort.
Yeah, and actually, this is really the secret of the success of the Mayo Clinic. They were among the first to implement the multi-specialty team, and that's paying off, no question.
100%. They really set the standard and created a gold standard for that multi-specialty team approach, and it's endless. The number of people you can think to help a patient like that: the radiologist, the interventional radiologist, the diagnostic studies, interventions, nutritionists, dietitians. I mean, it's just truly, it takes an army to take care of someone who's really, really sick.
It really does. And it's nutrition plays a huge part about it. And how many times do we forget about that, both as physician and both as the patients do as well? I can speak with my father, John, that there was so much information that was thrown at him. They hand out pamphlets and reading it. And it was just very overwhelming. It's very frustrating. And as older patients, they get very annoyed that they have to do a lot of this. So the more education we can do as specialists for them, it's more helpful for them to digest and understand what is going on and what they have to do. And for instance, when we talk about a dietitian for our diabetics, they can get 10 visits a year, patients on Medicare, with a dietitian if they have the diagnosis of diabetes or chronic kidney disease. And yet I treat thousands of wound patients every year. I think I had 2 took advantage of that last year, 2, because some of them say they know what to do. They just have to do it. But then you look at their hemoglobin A1Cs, which is a 3-month measure of how their sugar control is doing, and they're 16. Or some of them try to say, well, I don't understand, doc. I'm starving myself. I'm not eating anything. But we don't want them to do that either. You got to have a balanced diet and know this. So sometimes I wonder, how do we press upon the patients too, that they have to play their part, especially when getting them into these programs, which is very easy for that to do. So thus it is, without a doubt, a team effort to train and to teach both physician as well as the patient.
Excellent. Well, as they say, a picture paints 1,000 words, and you've shown some dramatic pictures, and unfortunately, those of us who are experienced clinicians have seen too many of these kinds of scenarios clinically in real life. But it's really led to some good discussion, and I want you to go ahead and introduce us to your prepare to repair paradigm here.
Yeah, this is, after 20 years, this is my 20th year of practice, and it just flies by, as you know, John. And so in our residency program, we teach residents this all the time. But after seeing these patients, I thought maybe there was something more I could do to help the general public, help other physicians, clinicians, nurses as well, because everybody is integral and central to the education paradigm. So I developed this called Prepare to Repair, because even though there's a very exciting things about what we talk about, skin substitutes and skin grafting and doing all those new things, you can't get to that point until you've prepared your tissue to repair itself. And again, the complex interaction of all the things that are going on, multiple things that conspire to create the wound. As you can see, there's multiple things that have to conspire to heal the wound. And they're no in particular order. It's just things that I have learned over those years. And so that we can make sure that we pay attention to each and every time we see these patients where things are going to get missed. And I certainly have missed some things earlier in my career because, if you look at it, oh, that's a venous leg ulcer. I know that's a VLU, right? And then it turns out to be a squamous cell or a basal cell or something of that nature. So I think that it's important for people to, and I train my residents to make sure each and every time, no matter if it's a repeat offender and you're seeing that patient frequently, always go through this paradigm in your head to make sure that everything is counted. And particularly blood flow issues play a huge part for healing, as diabetes causes plaque formation. We don't have enough blood flow to heal, especially in the vein, right? Bad reflux that's going on, feeding into those venous leg ulcers, whether it's in the leg or somewhere in the abdomen. If there is high pressures that are forcing back and causing that venous hypertension, and obviously the lymphedema component and the chronic inflammation that does occur from that as well. So that's why I developed this, and thank you very much for allowing me to espouse the virtues of this paradigm. And hopefully patients will see this and understand that there is multiple things that go on. There's not one thing going to fix that problem of that lower extremity wound, which 80% of all chronic wounds are on the lower extremity. But at the same time, hopefully some of my physicians and clinician colleagues will see some of this too, and also say, oh yeah, maybe I forgot about that, or maybe the biopsy component, or did you get the x-ray? How about the nutritional components that are going on? But also the blood flow issues. I mean, I don't know how many times I see patients that had wounds for a very long time, never had a Doppler. And in the venous realm, John, I've never even had a reflux study, but 15 to 20% of venous leg ulcer patients are going to have severe arterial disease as well. And I think people forget about the arterial component and doing Dopplers with toe pressure so we could elucidate those pathways down there, the small vessel disease, the microvasculature that gets occluded and causing these problems. So that's why I developed the prepare to repair paradigm to go over this, to reinforce that learning, to not forget about all those aspects.
Wonderful. Are there any particular elements of it that you'd like to sort of highlight for us?
Yeah, I mean, I think one of the biggest ones is talking about biofilm itself, because you have 1 billion bacteria per square centimeter on your body. So it's about 2.5 trillion bacteria. There is always going to be that component of bacteria and fungus, because we see a lot of fungal infiltration now in chronic wounds. This was just some little talking about the classic triad that we lead into diabetes. And we talk about that neuropathy component. And this the serious instigator when you have the destruction of these long nerves in the lower extremity caused by the high sugar. And the high sugar can change these things called the osmotic balance inside the nerve. And the insulating layer of your nerve, called the myelin sheath, starts to degrade. So the signal doesn't get from the lower extremity up to the brain for interpretation. It leaks out. And thus you can't interpret those painful signals. And we call that the stocking and glove distribution in diabetics. So toes to knees, fingertips to elbows is how this long polyaxonal neuropathy, dysfunctional neuropathy, occurs in the diabetic patient. So when they want to wear a different pair of shoes, or they get a rub, they're going to a wedding and they want to wear dress shoes and it rubs on their foot somewhere, and it starts into that cascade of having a wound. Now they have bad blood flow. And then that leads to the complications, then, of course, of uncontrolled infection. So that's just a quick triad of what happens in the diabetic people. But the mortality rates as well that we see in diabetics are like I said, up to 50% mortality rate in a diabetic, which is higher than anything out there, which is worse than anything out there except for pancreatic cancer. And considering that by the year 2030, 25% of the world will be diabetic, that goes to almost 52% by 2045. So these complications that you can see from just having a diabetic foot ulcer up to having a minor amputation, which we talk about as just a toe amputation, and the critical limb ischemia that develops because plaque builds up in the arteries, and then leading to major amputation with these death rates are through the roof. But I wanted to go in quickly to talk about diabetic foot ulcers. And there's an interesting thing that every 30 seconds.
Sorry, Matt. Can we go back to that slide just a second? Just for our viewers who may be lay people and looking at this, I just want to make sure, and I know you're trying to get through this deck quickly, which I appreciate because our time is limited. But I just want to make sure our viewers understand the impact of this. What Dr. Rogulski is sharing with you is if we use breast cancer as one disease that so many of us are aware of and have been touched by in our lives, the women in our lives and also men suffering and succumbing to breast cancer and all of the attention that breast cancer gets, what this graph is showing, if I'm understanding it correctly, is that the 5-year mortality rate, meaning the chances of dying within 5 years if you have breast cancer, is currently, it looks like that would be less than 10%, around 10% or less, if I'm estimating that correctly. Okay? Right. As compared to somebody who has what's called Charcot foot, which is a deformity of the foot, sort of an orthopedic deformity of the foot, where you get a rocker bottom kind of appearance, again, as Dr. Rogulski mentioned, because of nerve damage from the high blood sugar. This is a diabetic disease, Charcot foot. The 5-year mortality is more than 25% if you have diabetes and this abnormal anatomy of the foot as a result of the nerve damage. Now, you don't die from your foot. Make it clear, you don't die from your foot, but you die from the other consequences of diabetes, most commonly cardiovascular disease, heart attack, and so forth, stroke, kidney failure, etc. And then he has next to that DFU, which is diabetic foot ulcer. That's where a wound has formed as a result of longstanding diabetes or untreated diabetes, where the skin opens and there's an actual wound, an open wound, and that's even more deadly, a little more like 27, 28, 30% within 5 years, which is, according to this chart here, close to all cancers combined, the mortality rate of all cancers combined, which is outrageous, which is stunning to look at. And if somebody has had a minor amputation, quote unquote, a toe amputation, for example, a 4-foot amputation, which is considered a minor amputation, their chances of no longer being with us at 5 years is 50%. I mean, this is a dramatic graph.
Interesting, isn't it? How many people realize that? And I think that goes back, John, that we talked about. When you hear diabetes, you say to yourself, all right, okay, I can take a pill.
Yeah, my blood sugar, I have high blood sugar.
Yeah. Okay, I can eat what I want. I've actually had patients tell me when I look at their medication list, your past medical history, diabetes, anything of that. No, I'm not diabetic. But right here it says you're taking metformin, say, for instance. Well, yeah, they tell me if I take that pill, I won't have diabetes. So I don't have it.
That's the most common conversation in the world. They don't have blood pressure, diabetes, or high cholesterol.
Right.
They're on medication.
Yeah. I'm on medication. So, right. Or I can eat what I want.
I mean, I don't mean to smile. Right. Yeah. I eat all the ice cream I want, but then I take, some extra insulin or whatever.
Exactly. So I take the long-acting Lantus at nighttime. I'm good. I can. So, but that's what you hear cancer. You say, "Oh my God, I got to do this. I got to go here. I got to get this done." But that's what you hear cancer. We don't have those public service announcements or something about it showing the devastating complications, but also the population of the world that is becoming diabetic and then leading into all of these other diseases, because diabetes affects every system in the body. And we have 8% of the world's diabetics, but we spend 40% of the money on that treatment as well. But so, I don't know how to change that paradigm. Do we incentivize people to be healthier? Something I think has to give, because right now we're being reactive. We're being more reactive and not being proactive about helping them curb that inflammatory process that's going on in their body when they're in that pre-diabetic state, when they have some obesity and high blood pressure and their cholesterol is high. If we can get them out of that lifestyle modification, hopefully losing some weight, better exercise, and get them out of that pre-diabetic state, out of that high inflammatory state.
Well, a huge part of it is what we go over again and again and again on various subjects on the show. It's awareness and education, and that's why we thank you again for being on the program tonight. It's been already a phenomenal educational experience for our viewers, I think. But this slide is especially for our viewers who are patients, who may be a diabetic, who may have a family member who's a diabetic or are pre-diabetic. What we want to bring home, what we want to drive home with this graph is that diabetes is a deadly and serious disease. It's not just a matter of a blood test and having high sugar in your blood and that you can correct that with medication. It is a deadly, wickedly deadly and wickedly serious disease. And you want to never have it if you can avoid it. And if you have it, you want to control it extremely, extremely strictly. And that includes great healthcare, diet, exercise, and so on and so forth. And availing yourself to all of the wonderful healthcare opportunities that exist in the United States of America, like Dr. Gorski mentioned. If you have insurance like Medicare that allows you to see that nutritionist 10 times a year, see the nutritionist 10 times a year. If you're allowed to see a trainer, athletic trainer, or a physical therapist, anyone you can see, build a team around you, utilize the resources to save your life, because the loved ones around you are going to want you around for a long time. But I think already we've come to the take home for our viewers who are not physicians. I think we've had a take home message for our viewers who are physicians, which is ask for help, build a team. And for our patient layperson viewers, diabetes is serious, deadly, and devastating. And ask for help and make yourself open to that help and build a team of experts around you. This is all about building teams of experts to stop this devastating disease. I don't think people take it seriously enough, quite frankly.
No, I don't either. And I always try to empower my patients is that we ask for that help. When you talk to your primary, or you go to your podiatrist or your vascular surgeon, or ask for that about, should I be seeing other physicians, to treat these other parts. But again, even when we talk about 80 to 90% of diabetics will die from heart attack and stroke, yet I see diabetic people all the time that don't have a cardiologist. And I say to myself, wow, they have this disease and they're not understanding these ramifications. So me as a podiatrist, because they're coming in because of the wound they have on their lower extremity, at least I can get them over to the specialist. I get blood work done and we see that there's elevation of your kidney disease, because 150 people a day in the United States go on dialysis.
And again, these are great points. And for our physicians listening, I'm speaking now, not as a vein specialist, lymphatic specialist. I'm speaking now as a board-certified cardiovascular surgeon who did cardiac surgery for years in practice. When you see a diabetic with a foot wound, never forget cardiology consult. When you see a diabetic, never forget cardiology consult, because the most likely thing that patient is going to die from is cardiac disease, myocardial infarction, cardiac arrest. So diabetes, think heart. That's what's going to kill the majority of diabetics. Diabetes, think heart. Get a heart workup. And of course, always, as Dr. Rogolski is pointing out, check the renal function too. But number one, if you see a little black toe, a little infected toe, you think, it's just a little toe infection. Cardiology consultation.
Right, blood flow. And it's another thing, John, from all your years as being a thoracic surgeon, is people think that I've had patients that come to see me that have had wounds for a very long time. And I said, have you had the blood flow in the leg checked? And I remember this very distinctly. This just happened to me last week. This guy came in with two toes, John, that were gangrenous, fourth and fifth toes. And I said to him, had your previous physicians, did they check the blood flow? Did you have that done recently? I assume because you had gangrenous changes. And he said, no, because he said he could feel my pulse, that my blood flow was okay. I'd like to dispel that just a little bit and say, per the Society of Vascular Surgery, that the palpation of pulses don't include or exclude the diagnosis of vascular disease. You need a quantifying examination. And I can show multiple papers where patients had palpable pulses, but had hemodynamically significant lesions in their arterial tree. So please, if you have anybody with a wound that has risk factors for vascular disease, irrespective of pulses in their foot or not, get your arterial Dopplers done and go all the way down to those toes. Do not stop at the ankle, because in the diabetic population, they get calcified and they get falsely elevated. So please always have that vascular study done. And in our venous leg ulcer patients, again, do the venous reflux study as well. And if there's problems with that, see a vein specialist like Dr. Chuback, but at the same time, get that arterial Doppler done, because we need to know chronic inflammation creates plaque inside the arterial tray. So I think that's important, very important.
And actually, there was a absolutely fascinating recent paper that was originated from the International Union of Phlebology, talking about the interlocation of several possible pathologies, because all these chronic diseases are always touching endothelium, provoking having the inflammatory reaction, having the oxidative stress, having the thrombosis issue. And so whenever you have the patient with the, even with the just severe varicose veins, it looks like it's worth to look into the arterial side, because those patients may have the other pathologies. And I think that you are so right, bringing the underlying the importance of seeing the whole person, whole patient. The wound is only a part of it, but you have to see if there is another pathology that it's contributing to it. It can be, mixed. It can be venous, arterial. It can be cardiac or other origin.
Absolutely. And I think one of the take-homes here for our physicians listening, who, if this may not be your primary area, if you're a primary care doctor, internist, family practitioner, etc. And I hate to say this, I've even seen vascular surgeons make this mistake. So this is for everybody. Historically, what Dr. Rogolsky is pointing out is the importance of pulses. In many patients, normal pulses is a very good sign, especially if you're a non-diabetic. But diabetics get what we call small vessel disease. And so those patients, historically, we looked at what we called ABI, ankle brachial index. And a lot of my podiatry colleagues in recent years, et cetera, were insisting on what we call TBIs, toe brachial indexes. And that is not something that every center is doing, but that TBI is very, very informative to give us more information about microvascular disease, which is extremely insightful into the patient's risk for limb loss and also for end organ damage, cardiac disease, renal disease, et cetera. Matt, do you want to?
Yeah. Without a doubt. When we talk about that small vessel disease is microvascular disease, but that's also not only in the foot, but that's what leads to the problems in your eye, your kidney, and with your nerve is microvascular disease. And I also want to point out, too, that people that have collagen vascular disorders, psoriasis, lupus, rheumatoid arthritis, scleroderma, also have significant increases in cardiovascular disease because of the chronic inflammation, affects their endothelium, affects their arterial flow, affects the oxidative stress, leading to that atherosclerosis. So we don't want to forget about that population as well, because I have a significant population with collagen vascular disease that have wounds from that as well. And we always want to check that blood flow on them, because they also have increased risk of peripheral vascular and cardiovascular disease as well, because it permeates throughout the body. The artery is the same in your toe as it is in your brain. It responds the same way to that inflammatory nidus. So it's important that all those states we look at.
It's what we call a systemic disease. And one of the things that I think is important for physicians and patients both to understand is that when it comes to the vascular system, the arterial system, for example, as Dr. Rogolsky is pointing out, you don't get eye disease or kidney disease or toe disease or myocardial heart disease. Your you have a systemic vascular arterial tree that goes through all of the organs of your body, feeds every organ of your body. And that arterial tree should be seen as one gigantic organ. And it's equally susceptible to this chronic hyperglycemia everywhere. So if you see it in a toe, you have to be worried about the eye, the kidney, the heart, etc. So this is the great teaching point from today's discussion. I know if our dear friend Dr. Mark Melin were here, he'd be talking about the effect of this inflammatory response on the glycocalyx and how important that all is. But
Yes.
right. Unfortunately, Matt, we're coming near the end, so I want you to pick a slide or two to finish it. I know we'll never get through all of your slides. It's just, it's so rich, it's so abundant, it's so valuable. We could have you on for 5 more shows to go all of this. But let's try to wrap it up with what you think is going to be the most important take home at the end.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
Okay, so I want to just real quick talk about biofilm and what that just is. So when we have these chronic wounds, I don't know how many times I've seen patients getting antibiotics for their chronic wounds without the true indications of an acute infective process: red, swollen area, purulent drainage, massive odor, exposed bone, tendons, things of that nature. Antibiotics do not heal chronic wounds. So that's why we have these problems that we have. And when we talked about antimicrobial resistant infections, we thought by 2050 that we were going to see this problem. But unfortunately, 2 really good papers in the Lancet that came out showing that 5 million people have died now from antimicrobial resistant infections. And in fact, the CDC here in our country is called every 30 minutes on an antimicrobial resistant infection. So I think the biggest thing to take home about what biofilm is, Dr. Chuback, is that it is a protective mechanism that bacteria and fungus spin around themselves inside a chronic wound so that they can live free from the antagonistic effects of our immune system, from antibiotics and these things called and biocides as well that we put in to kill them. And it's a big sugary cloud. I call it the house of the biofilm mass. It's a big sugary cloud. It's composed of mostly sugars, but there's some protein in it and DNA as well, and some lipids in these in the biosurfactants. But it's 90% of that dry weight of the biofilm mass is that big sugary cloud that is spun around. There's only about 2 to 10% bacteria that is inside there. But that big sugary cloud becomes a protective layer. Your immune system can't get through it. Your white cells that digest bacteria and damaged parts have a very difficult time, if all, getting through there. Antibiotics can't get through to that. We can't get those flow rates high enough out of the plasma from taking antibiotics to bust through a biofilm without blowing out patient's kidneys. So this was just a quick picture of one of the first total hips that were removed because of biofilm. This is 1973. And when you look at it under an electron microscope, you can see that there. So I guess I want patients to understand that antibiotics do not heal wounds. I've seen one patient for her VLU, John, that had 8 different antibiotics in 8 months for her chronic ankle ulceration. So I think it's important for us, again, when we go back to the prepare to repair paradigm, that biofilm treatment is critical. And we want to be able to treat that with something that can digest that away, but at the same time, not harm your good mammalian cells. So I hope patients and clinicians understand that antibiotics do not heal wounds. So we have to stop perpetuating antimicrobial resistance, because you and I see it all the time in the hospital now. The bacteria and fungus are becoming highly resistant to out there. And there's not much research going on for new antibiotics in the pipeline right now, because it's very time consuming. It's not a lot of, I hate to say it, but it's not a lot of profit engendering to pharmaceutical companies to make new antibiotics. So we have to think about different strategies for treating that and treating it topically. This is just the structure real quick of what the EPS looks like. This is called the extracellular polymeric substance. And it's these metal ions that are linked to these different sugar polymers. And inside that is only 2 to 10% bacterial. The rest is this big sugary cloud. So there are ways to defeat that. There are ways to attack that and rip it out of there and keep it gone for an extended period of time that we can treat that topically. But I guess that could be for other shows that we can get into. But I wanted patients to understand that just taking antibiotics is not going to heal your wound. There's multiple things that conspire to create the wound, multiple things that have to conspire to heal the wound. You have to prepare that tissue to repair. Biofilm is there. You can't see it. You need electron microscopy to see it, or confocal laser microscopy. But it is there, and it's there anywhere we implant stuff, John, right? We do PTFE bypasses, when we put in pacemakers, when we put in total hips, total knees, when we put in, PEG tubes, when we're putting catheters in for recurrent urinary tract infection, when we're implanting hardware for ankle joint replacement and things. Anywhere that we can put an implant in, bacteria can attach, but also it's a cause of all these other chronic problems, chronic UTIs, for gastritis, for otitis media, for pulmonary fibrosis, for chronic osteomyelitis as well. These are essentially biofilm-driven infections. And in fact, the NIH tells you that 80% of all infections are due to biofilm. So it's a real tangible disease state that we have to be able to treat. It's highly specialized, it's very complex and very difficult to eradicate. You can take a nice blade and debride a wound and rip open a biofilm, but it will start to reform in 5 minutes and be fully mature again in 5 hours. That's the fascinating structure that these little one-celled organisms can put together to defeat our multicellular immune system as well. So I just hope patients understand and physicians understand that just giving antibiotics for a chronic wound is not going to do much of anything. There's no evidence for it, first of all, but at the same time, it's not going to fix the problem, because there's multiple things that have conspired to create that wound, multiple things we have to do to heal the wound.
Right. Well, that's beautifully stated, and it's a great explanation of biofilm. And a couple of things that I'd like to add for our physicians who are listening that may be helpful in how you think about this. I remember many, many years ago as a general surgical resident, one of my professors, Dr. Charles Sills, who's no longer with us, who was a great thoracic surgeon, and we dealt with a lot of very sick, complicated patients together over the years, the 5 years that I was with him training. One of the things that he taught again and again, and this escapes many physicians throughout their whole career if they haven't had this discussion, with open wounds, there is a huge difference between an infected wound and a contaminated wound. Every open wound is by definition contaminated, but that's different than being infected. And if it's opened and drained and debrided and open to the air, and there's no pocket, there's no collection, there's no abscess, etc., the vast majority of those times, in those cases, that's a contaminated wound, which will heal with proper treatment, but it does not require antibiotics. So that's the first thing. There's a huge difference between contamination, as Dr. Gorski pointed out. We have 1 billion microorganisms per square centimeter on our skin surface. So our skin is contaminated, but we don't need to walk around on antibiotics all the time because we have an intact immune system. So a wound which is open and draining and there's no loculation, there's no pocket, there's no abscess, etc., typically does not need antibiotic. Now, if the patient has cellulitis, crepitus, that's a different subject. But just an uncomplicated wound, there's a difference between contamination and infection. The other thing I want to say that you pointed out so beautifully here, which I think is another misunderstanding, the sluffy material that we see in wounds that I grew up in my training, we referred to as fibrinous exudate, which sits in a wound that gets easily debrided out with sharp curettage, et cetera, pulse evacuation, et cetera. This is not biofilm. What you're seeing, that gross, heavy overburden of devitalized material in a wound that can easily be debrided out, that's not biofilm. I call it fibrinous exudate. It's important to clean that material out. But as Dr. Rogolski said, and you can repeat it if you like, biofilm is seen with electron microscopy, correct?
Correct. Yes.
Not with the naked eye.
Not with the naked eye. You're right. That slough that we see, that's the result of the chronic inflammatory process, chronic tissue destruction, developing that fibrinous slough. Absolutely.
But I think that there are physicians doing wound care who, when they debride that material sharply and they get that exudate, that fibrinous exudate out, they think they've removed all of the biofilm. That's a misunderstanding.
It's misunderstood, and it can be deep. I mean, biofilm can penetrate.
It's at the base. It's at the base of the wound, and it's deep and into the tissue.
Yes, right. So that's why we think about just giving an antibiotic for it. You're exactly correct, John. Is that because if you don't see those acute signs of infection, big zone of redness around, purulent exudate, heavy odor drainage, exposed bone, tendon, hardware, those types of things. Chronic wounds, antibiotics do not heal chronic wounds. Absolutely, John. Thank you for pointing that out.
Great. Well, Monika, we could go on and on. It's been a terrific session. I've really enjoyed it. The slides are great. We're going to have you back.
Yeah, I look forward to it.
It's a real privilege. Your knowledge is obviously world-class in this subject matter. Monika, any final thoughts or remarks?
Yeah, and my final thoughts are also related to the factors that are favoring the biofilm. And I think certainly, some elements in the pathophysiology of the wound are extremely important. Like, for example, the presence of edema. This is something that it's absolutely devastating. And I think that, honestly, I think that one part of the efficacy of the MPFF, so the flavonoids in the wound healing, is the anti-edema activity and the activity on the capillary permeability, restoring the normal endothelium, and that certainly helps. And certainly, what what you presented, it's a very comprehensive paradigm of for the wound treatment. And I'm looking forward to everybody to adopt it and to really follow you.
Well, thank you very much. You're right. I mean, MPFF has a significant effect upon and that's what our paper was talking about, how chronic inflammatory processes, infection affecting that thing, the endothelial glycocalyx, the permeability of those endothelial cells, and kind of backfeeding in the biofilm mass itself, without a doubt. Thank you, Dr. Gloviczki. I appreciate you pointing that out. Fantastic.
Well, with that, I think, Paul, we're going to sign off. Before I give it back to you, Paul, I'll mention one more time the Vein and Lymphatic Summit 2024, VLS 24. Folks who are interested could go to vls24.lerexpo.com and read about the faculty and the agenda and so on and so forth. And we may have some new surprises. We may have some new people and talks even added to that agenda. So it's only going to get better before mid-July when that amazing conference, totally virtual conference, takes place. And don't be completely surprised if Dr. Matt Rogolski shows up on that faculty either.
I would be honored and privileged to be a little small part of that. Thank you. That would be my honor.
That would be great. We're going to see what we can do. If we can pull any strings with the big boss. If
Yeah.
you know what I mean, Monika.
Old Rich, yeah, he's a good dude. He's a good.
Great.
Great.
Paul, go ahead.
Yes, sir. And Dr. Chuback, to be sure, make sure I have it straight so everybody else does. When they go to that website, they do have to register, right, to be an attendee or not necessarily?
That's correct. They can register. I believe the early bird registration is still open, so there's some significant savings right now. That's going to run out pretty soon, I think. So again, vls24.lerexpo.com.
Okay, very good. Thank you again for tuning in tonight, watching and or listening to our show, LymphCast. It's been episode 54. And again, please feel free to visit the website early and often. It's there for you 24/7, lymphcastnetwork.com. If you have a question for anybody on the panel, you can email it to us, hello@lymphcastnetwork.com, and that's on that website as well. Let's go around the table. And before I thank Dr. Chuback and Dr. Gloviczki, Dr. Chuback, if you don't mind, can you thank our special guest one more time?
Well, Dr. Matt Rogulski, thank you again for being here. It was, even for me, as a cardiovascular surgeon, vascular surgeon, involved in wound care and major vascular disease now for close to 30 years, these images are still shocking and heartbreaking, but also, I think, inspiring and motivational for those of us in healthcare, knowing that we still have a lot to do to educate ourselves and our colleagues and one another and the public. It's a never-ending process, as you pointed out, of education for ourselves and for the medical community at large. So thank you again for your insights into this important subject of diabetic disease, diabetic foot ulcer, diabetic infection, limb loss, life loss, etc. Thank you so much for being with us.
Thank you, sir. It was my great pleasure and honor to be in the company of such learned and visualizing people as yourself. Thank you for having me. And I look forward, hopefully, maybe to be on again. We can go over more of that stuff. Would be wonderful.
All right. Thank you for being here, sir. Also from Arizona, Dr. Monika Gloviczki. Thank you, Dr. Gloviczki, for everything once again.
Thank you for having me. And Matt, please come back, because we only touched, the surface of the problem. So we probably have for an hour another 2 sessions, maybe. Am I realistic?
Right. At least I would love to. It'd be my honor. Yeah. If you invite me back, I would come anytime.
All right. We will take you up on that, right, Dr. Chuback?
Yeah.
No question about it. My wheels are already spinning.
Thank you, sir.
He offered. Let's take him up on it.
I'll be there anytime.
All right. Also, the gentleman who started this show, he's also the founder and owner of Vita Support MD. They make Vein Formula 1000, Lymphatic Formula 1000 from New Jersey physician, surgeon, Dr. John A. Chuback. Thank you, Dr. Chuback, for everything.
Thank you, Paul. It's been a pleasure. And as always, I probably learned more than anybody else out there listening. It's always inspirational, educational, and motivational. And to our patients, as I always say, don't forget, there's always help and there's always hope. If you're not feeling well, if you're sick, if someone you care about is not feeling well or sick, not only for the subjects that we cover here on the show, but for any medical reason, reach out, see a doctor, see a healthcare professional, and don't be deterred if you're not happy at first. Get another opinion and another opinion until you're satisfied that the care you're getting is truly what you deserve, which is world class.
Very well stated, as always. Thank you, sir. And again, you've been listening to LymphCast episode 54. Have a great evening. We'll see you next time for LymphCast episode 55.